Thank you all for joining. We're so glad to have you at the Health Services Research Grand Round, supported by the UH Health Services Research Center. For our attendees, I'm going to give everybody about 1 more minute, and then we'll get started. Just so you guys know, and I think when you joined, it notified you that it's being recorded and will be available afterwards to view. So we'll give everybody 1 more minute, and then we'll get started. Okay. So I'm Molly McVoy. I'm a child psychiatrist. I am a neuroscience and child psychiatry researcher and a frequent collaborator of Martha's, and I'm thrilled to be your moderator to facilitate today's talk. As I mentioned, for those of you that joined before, this is being recorded and will be available to view afterwards. If you're joining, please mute your microphone throughout the presentation. If you need any technical assistance, Nicole Bollinger, that is on this, is available, and you can message her, or also feel free to message me and we can get technical assistance sorted out. If you prefer to put things anonymously, you can submit those and I can see those. Questions are seen by all the attendees, and there are within the chat options that you guys have available, and I'll be monitoring as Dr. Sajatovic is speaking. So with that, with the housekeeping items taken care of, it's my pleasure to introduce Martha. She's a professor of psychiatry and of neurology at Case Western Reserve University School of Medicine. She's a researcher, educator, and clinician who has devoted herself to the study and treatment of traditionally hard-to-treat populations within the central nervous system. Dr. Sajatovic holds the William Brown Chair in Neurological Outcomes at University Hospitals, Cleveland Medical Center, and directs the Neurological and Behavioral Outcome Center at UH-CMC and Case Western Reserve. She has subspecialty certification in behavioral neurology and neuropsychiatry. Her research interests have focused on neuropsychiatric outcomes of brain disorders, including Alzheimer's disease and other types of dementia, stroke, epilepsy, and Parkinson's. She also has research interests in self-management of chronic health conditions, such as hypertension and diabetes, especially in health disparities and in underserved populations, using specific rating scales that help measure and assess those hard-to-reach populations. Dr. Sajatovic is the developer of the SMART Epilepsy Self-Management Program and has been involved in the CDC-funded Managing Epilepsy Well Network for over a decade. She also leads the Outreach, Recruitment, and Engagement Core of the NIA-funded Cleveland Alzheimer's Disease Research Center, otherwise known as the CADRC. Over the last 2 decades, she has been the recipient of multiple research grants, that's an understatement, and authored over 400 peer-reviewed publications and published over 40 book chapters or books on neuropsychiatric topics. Given her exemplary research achievements, she's received numerous awards, including the Exemplary Psychiatrist Award, bestowed by the National Alliance for the Mentally Ill, which is a patient advocacy group, which is particularly impressive in my opinion. The Depression and Bipolar Support Alliance 2006 Gerald Klerman Investigator Award. The Rebecca Goldberg Kaufman American Epilepsy Society Clinical Award in Ethical Neuropsychiatry in 2018. And in 2022, she was recognized by the American College of Psychiatrists Award for Research in Geriatric Psychiatry. Without further ado, let me welcome and pleased to have Dr. Sajatovic join us. Thanks, Martha.
Thank you, Molly. Thanks for the very kind introduction, and I appreciate the opportunity to share with our health services audience today. Let me pull up my slide, and hopefully I'll be able to do this correctly. Okay, so hopefully you're looking at a slide view there.
Perfect.
Awesome. Okay. So, as Molly alluded to, I've been working in the space of epilepsy self-management for over a decade and have developed a self-management curriculum called Epilepsy Self-Management for People with Epilepsy and a History of Negative Health Events. The acronym is SMART. And what I want to share with you today is a science to service model, is the journey that my team and I have had over a decade plus to developing a program, testing it under reasonably rigorous conditions, and then being able to ideally scale that up and eventually have it be part of a current standard of care with the ultimate goal of advancing care for people with epilepsy. You have my disclosures here. Our objective today is hopefully you'll be able to define epilepsy self-management as an evidence-based chronic disease management approach, gain familiarity with research approaches that will develop, test, and implement self-management interventions, and identify approaches that will build partnerships that can facilitate implementation and scale-up of these evidence-based self-management approaches. So it really is a spectrum that I'm going to be speaking about today. Just to give you a little bit of background about epilepsy, for those who may not be super familiar with it, epilepsy is one of the most common neurological conditions. The hallmark is that people experience recurrent seizures. Very often those seizures are unpredictable, so the person just doesn't know when it's going to happen. Over 1% of the total US population has active epilepsy, and that translates to close to 3.5 million people nationwide, 3 million adults, and close to 500,000 kids. Epilepsy can have the onset really at any point across the age span. In later life, it can be acquired with things that cause brain injury, like a traumatic brain injury or a stroke, or other often aging-related conditions. Just to give you some point of reference and comparison, so if we look at epilepsy numbers versus breast cancer, I've used here as an example. So number of cases, 3 million for epilepsy, 4 million for breast cancer, and you can see the comparison of the new cases per year. And then I think, one sobering thing I just want to draw your attention to is the deaths per year. So 43,000 for breast cancer, 50,000 for deaths per year. So people with epilepsy can have, premature mortality for a bunch of reasons. There's something called sudden unexpected death in epilepsy, but also people are at risk for premature mortality for a bunch of other reasons, and I'll talk about some of those in a moment. So epilepsy self-management, this is a topic that I've devoted a considerable part of my career to, refers to the processes that are used to control seizures and manage the effects of epilepsy. Most of the current successful models that we have are derived from chronic illness self-management templates. So that's an evidence-based approach. There is data to suggest that ESM, or epilepsy self-management, can have biological effects on the people that participate in those programs, reducing inflammatory biomarkers, heart rate variability, and other stress hormones. So self-management, epilepsy self-management is a good thing. It can lead to a variety of positive health effects and overall health effects, but there's a lot of barriers to ESM. We have evidence-based treatments that are anti-seizure, have anti-seizure effects. People can forget to take them. The medicines may work up suboptimally. They can have side effects. We'll talk about mental health comorbidity in a second. Unfortunately, epilepsy, like a number of brain disorders, is a stigmatizing condition. So people experience discrimination and social exclusion because of having stigma. That can lead to local lack of social supports and sometimes lack of access to care. There are other things that can cause barriers to care access, including geographic location where somebody might be living and the availability of resources and services. Epilepsy, in addition to having the neurological effect of the seizures, it is a condition that's often associated with very high stress levels in people who are living with epilepsy. One of the really supreme challenges is the unpredictability of when seizures occur. Some people do get what we call an aura, where they kind of know they're having a seizure, similar for, migraine or some other prodromal symptoms, but not everybody. For many people, unfortunately, they just come out of the blue. So it's perhaps not surprising that people with epilepsy have 2 to 5 times increased risk of developing any psychiatric disorder. 1 in 3 people have a lifetime psychiatric diagnosis. And unfortunately, having a psychiatric comorbidity is a poor prognostic marker. So whether you're getting treatment with drugs or epilepsy surgery, the outcomes tend not to be as good or as robust as in those without psychiatric comorbidity. I have been part of a CDC-funded organization. Whoops, I'm not sure what happened there. Called the Managing Epilepsy Well Center. The mission of the MU network, goodness, this must be on an autopilot, is to develop, goodness, I am really sorry. I'm not sure why that happened. I'm going to stop my share for a moment, if you'll bear with me, and redo.
And while you're doing that, Martha, if you guys have questions, I just want to clarify, I think only I can see the Q&A. So don't hesitate to put those questions in, the panelists, and I can see them, and you can do that as we're going, and I'll keep track.
So the mission of the MU network is to advance epilepsy self-management by facilitating and implementing research, conducting research in collaboration with stakeholders, and broadly disseminating the outcomes. We've had 5-year funding cycles. We're just ended one. I am really sorry, guys. I don't know why this is happening. Let me stop my share and see if this must be on slide advance. So if you'll bear with me. Very strange that it was not doing that before.
Gotta love technology.
Okay, I'm going to skip those slides and go to the CDC framework. So I've been part of this Managing Epilepsy Well network now for over a decade. And we develop and then test epilepsy self-management programs. And so there's a whole spectrum that we follow, including building the system, so the intervention, evaluating it, disseminating it, then ideally doing community-based pilots, kind of rinse and repeat, going back and evaluate. And then the holy grail here is figuring out how to sustain the system or the intervention. Ideally, in the healthcare setting, they would be supported by appropriate reimbursement and cost studies to help make the case, and hopefully a strong case, about why health organizations should engage in and have these self-management programs be part of their clinical framework. So there's been a number of MU network self-management programs. Here's a listing of some of them. The SMART program that I'm going to tell you about and the TIME program that I'm going to tell you about are ones that we've developed here at Case Western and at University Hospitals of Cleveland. There are a number of other evidence-based programs. I won't be talking about those today. One of the first programs we developed was a program called TIME. It was targeted illness management for epilepsy and mental illness. We developed it in 2 phases. So this was a pilot efficacy trial in phase 1. We had a community advisory board. We received iterative input, and then we developed a group-based intervention for people who had both epilepsy and serious mental illness. So kind of a hard to reach, hard to engage population of people with epilepsy that we know tend to have poor outcomes. We enrolled 44 people. We randomized them on a 1-to-1 basis, treated them with the TIME program versus treatment as usual, and then our primary outcome was depressive severity. We used peer educators. So this is the secret sauce of TIME and other programs that we've developed. And these are people who have epilepsy. They're experts by experience. We've used the Case Prevention Research Center to ensure stakeholder input. We also reached out to community agencies. And our questions are, who are we serving? Who are we missing? How can we improve? And they gave us some really valuable input to develop the TIME program. I mentioned we had 44 people enrolled, average age close to 50. We had more than half of our people with epilepsy were African American. The majority were unemployed. They tended to be in limited financial circumstances with annual income of under $25,000 per year. We did see that our TIME intervention looked like it worked on our primary outcome. Our primary outcome was the Montgomery-Åsberg Depression Rating Scale, and we saw that people that were in TIME had greater improvement in depression severity compared to those who were in our treatment as usual. The effect size was 0.7, so it was pretty robust. So we then took that and said, all right, let's think about this in the sort of grand scheme of epilepsy self-management programs. And one thing we did is we took the Institute of Medicine Universal Health Interventions framework and adapted it for health promotion epilepsy. So we can think about three main categories. The first would be universal HPIs or health promotion approach. This would be applicable to all people, an approach that's minimally invasive, it's easily disseminated. Standard education is a good example. The Mu Network developed a program called Webbies, again, self-guided, self-learning, pretty low burden and low intensity to implement. Then the next would be selected HPAs. So we could target those with poorly controlled epilepsy, those who have comorbid depression. It's individually or group tailored. And the program that I'm going to tell you about in a minute, SMART, is an example. The third category would be indicated HPAs. So that targets those who are at very high risk, those who have serious mental illness or more severe depression. TIME, the intervention that I told you about, is a good example. So that was an in-person intervention, pretty high burden, high intensity. But for people that, have really kind of a very risky outcome and potentially very poor trajectory, it definitely can lead to improvements in health. We were able to get some funding from the Cuyahoga County Alcohol, Drug Addiction, and Mental Health Services Board to support some of our work in epilepsy self-management, which is a nice example of that spectrum that I showed you, being able to scale this up or disseminate this to the community. Based on the interactions and the experience that we had with the Adams Board study and with our efficacy randomized control trials, we thought it would be important to kind of scale back. We decided to go with that kind of middle road for the HPA, something that would be more broadly applicable. We developed this program called SMART. It consists of 8 group format sessions. Now, these are all delivered in a web-based format using posters and graphics. It emphasizes an interactive style. Telephone call-in is available for people who don't have web access. The group sessions are completed over the course of 8 weeks. There's a pretty detailed curriculum and semi-scripted instructions for delivery. Again, the secret sauce is the programs are led by a nurse or health professional and a peer educator, a person with epilepsy who's trained in the SMART program. The peer educators are really critical. They serve as experiential guides to support the group participants. They're not perfect models of health. We tend to look for people who are, willing to share their struggles in self-management and in their epilepsy journey. And one of their key goals is to help people in their groups realize that they're not alone and that learning self-management takes time, but it can have a very high return on investment. And one of our mantras is we learn more from our mistakes than our successes. So being able to share both our mistakes and our successes can be a really valuable resource to people in the SMART groups. This is what the curriculum looks like. I won't go through all of this, but we talk about important topics. We address stigma early on. There's something called double stigma. So stigma related to having epilepsy, and then an additional stigma burden related to having mental health comorbidity. So if you have both epilepsy and a mental health condition, we would term that double stigma, although one of our peer educators a number of years ago explained it, I thought, most beautifully, where he said that stigma plus stigma, or 1 + 1 doesn't equal 2. It's more like 1 + 1 equals 4, that it really just is compound stigma. We talk about treatments for epilepsy, and then we introduce some problem-solving skills. We help people to communicate with their healthcare providers. A lot of people really encounter challenges with that, and sometimes they vote with their feet and they're not engaged with their treatment, or they're suboptimally adherent with medications. This will help people with that so they can communicate their needs and work with their providers to find solutions. We talk about nutrition, exercise, stress management, using social supports, and normalizing your life in spite of having a chronic but unpredictable condition. After those groups were done, we have a second phase, which is some follow-up after the groups, to work on personal goals with the smart nurse educator. So then we did a randomized controlled trial where we enrolled 100 people, 120 people with SMART. Half of them were randomized to SMART, half of them were randomized to waitlist. The design was similar to what I showed you with the time program. Our primary outcome was negative health events. So these are complications for epilepsy. That was defined as a seizure, a hospital visit, an emergency room visit, or a self-harm attempt. And we chose negative health events, or NHEs, as a primary outcome because some studies just looked at health resource use, and one of the problems with just looking at health resource use is there's good health resource use and there's bad health resource use. So if you use the emergency room as your primary care facility, that's probably not an ideal resource use. But on the other hand, let's say you've put off going to the dentist or getting your mammogram because you're worried you might have a seizure, and now you're doing better because of your epilepsy self-management program and your support, and you kind of get on the stick and you go and get your dental care and your mammogram, you might actually see an uptick in health resource use and services, even though it's timely and it's important. So we chose negative health events because I think we can all agree that having an emergency room visit, hospitalization, a seizure, or a self-harm attempt are things that nobody likes to have in their life. So our primary outcome was NHEs. We did see that compared to waitlist, 6-month waitlist, SMART was associated with reductions in total NHEs and NHEs counts. We did see, just like with the time study, that was improved depressive symptom severity as well as improved quality of life in epilepsy. So then we got some funding from the CDC to do an effectiveness trial. So this was, less of that kind of laboratory-based, controlling everything kind of trial as we did with our first efficacy trial. We did an 18-month randomized control trial of SMART versus 6-month waitlist. We enrolled at 2 sites, Iowa and Ohio. We prioritized enrollment from underserved and rural settings. We did the same type of intervention, so I won't go over all of that. Here's our inclusion criteria, similar to what we had in our efficacy trial, but intended to have a broader expanse in the real world population. So, all they had to be was an adult with epilepsy. They had to have at least 1 NHE in the last 6 months, because that was our primary outcome. They needed to be able to participate in the groups, be able to speak and understand English, but otherwise really no other, any comorbidity, substance use, poor adherence. Didn't matter how many seizures they were having or what their medical status was. That was fair game, and we welcomed everybody. Now, I want to give you some background here on our rural outreach. So to quantify residency status based on the urban and rural continuum, we used the U.S. Department of Agriculture Rural and Urban Continuum Codes, or RUC codes. Those codes go from 1 to 9. 1 is the most urban, 9 is the most rural, and they're calculated based on a number of factors, including how close they are to a big city and the different types of the population, the services available. We were enrolling in both Iowa and Ohio, and I just wanted to draw your attention to some differences between Ohio and Iowa. They're both Midwestern states. But if you look at the RUC, so this just shows you RUC codes 4 to 9. So these are the most rural counties. And what you can see is if you look at those sort of red, purple, and brown codes, we don't have very many of those in the state of Ohio, right? They're mostly toward the kind of urban part of the swimming pool. Whereas in contrast, Iowa has a lot of, much more rural end of the spectrum. So we do believe that cumulatively, we were able to get a diverse population, including a good number of rural folks that you'll see in just a minute. Prior to running this effectiveness study, we did some modifications to make sure that the curriculum would be appropriate for rural populations. We had some focus groups. We had a stakeholder advisory board. They gave us some suggestions around implementation and suggestions for improvement, including how to help for people who had internet or cell phone access issues, how we might reach out to people, how we might train our peer educators, and targeting locations to get some of our hard to reach populations. What we've seen again and again in self-management studies is that we tend to get more women than men when women tend to be more likely to volunteer to participate in groups. So we did some targeted outreach to locations where we thought we could reach more men with epilepsy. We enrolled 160 people in that effectiveness trial. The yellow targets, the yellow pings are the Iowa team enrolling, and you can see that really is focused around Iowa, Iowa City. The team at Case are the blue markers, and you can see that we really had a national representation. So we advertised on the Mu Network website for people. We reached out to stakeholders and other organizations that provide epilepsy self-management services and got a number of referrals from some of these entities. So I would say that we definitely went national with this. This is our patient sample or participant sample, average age around 40. We still got more women than men, but we still got over 30% men, so consider that to be reasonably successful. Educational level was relatively high, so over 3/4 had more than a high school. But look at the difference. So in terms of employment and income, so what happens unfortunately with epilepsy is people may be able to complete school, especially if they have some supportive services, but being able to hold employment and earn income is definitely compromised because of epilepsy. And people might be on disability, they might have limited health insurance. So you can see that less than half of our people have private health insurance. This is what our RUC breakdown looked like. So we enrolled almost 20% in the most rural settings, and then another 35% in that 3 to 5 RUC. Not quite half in the more urban. So, that sort of is explained, I think, by those little pointers that I showed you about where we were trying to enroll. And most of our urban individuals did come from the Iowa site. One of the analyses that we did, because we oversampled for people from rural settings, was to see whether geographic location made a difference in terms of seizure frequency. So this little chart shows you a sample out of our initial 94 enrollments who were in that RUC 1 and 2, sort of most urban, and then the mid range of RUC 3 to 5, and then 6 through 9, which is the most urban sample. And what you can see is if you look at the bottom 2 rows is that people with epilepsy who lived in rural settings were more likely to have a higher seizure count or higher seizure frequency. So that's consistent with the literature. It probably has to do with access to services for those who are living in rural settings. And we did hear many times from people who participate in our groups that, to get to their epilepsy care appointment, they might have to drive 3 or 4 hours. And so they would limit the number of times that they would go in. They couldn't as easily make a unscheduled visit or get unscheduled services. And it was far and few between that they could actually see the clinician, thereby making it even more important that they have good epilepsy self-management skills. We did another analysis looking at stigma. So I had mentioned that epilepsy is a highly stigmatizing condition still. It's very stigmatizing all over the world. I think probably better in the US than in some lower and middle income settings, but unfortunately stigma is alive and well. This is an analysis that we did of our baseline sample looking at stigma scores based on the Epilepsy Stigma Scale, or ESS, in relation to some other variables. And we can see that generally stigma correlated with worse self-efficacy, sort of confidence and ability to manage your health, less social support, worse overall health, and greater depressive symptom severity. So, again, thinking about some of our really vulnerable populations, people who are living in rural settings who, tend not to have much social support and much services support. So as we continued, so we did that, pilot work, we developed time, then we developed SMART, and we did a kind of more rigorous efficacy RCT, and then we did the effectiveness RCT. We have been thinking about the implications for clinical practice. So we know that evidence-based ESM can reduce stress, depression, epilepsy complications, or NHEs can improve quality of life. But still, it's not a standard of care currently, and it's important to see if we can get epilepsy providers to engage more widely with this, and then partner with community and clinical stakeholders to figure out an efficient and practical way to scale these programs up into both community and clinical care settings. So there are a number of barriers as to why ESM isn't typically integrated into epilepsy care workflows. Reimbursement can be challenging and inconsistent. There's staffing support, staff training, a bunch of barriers. I won't go into those now, but there are clinician-facing gaps. There's patient-facing gaps. People may not be aware that these programs even exist. Digital access is still a problem. And then we don't have intervention. So all of our work has been in adults age 18 and older. We get asked very frequently, do we have something like this for kids, for adolescents? People have been diagnosed with epilepsy as infants or children. I would say stay tuned. Molly's been trying very hard to get some funding and support to adapt SMART for kids. I think she's going to get funded eventually, but it's still a critical unmet need. There are system service gaps. So training providers take time. Depending on the clinical programs, there might be different needs. We've definitely seen that clinical programs have different needs from community agencies. And then whenever you're going to offer an intervention, establishing fidelity is important. Fidelity drift can be a problem, and we have to find out ways to make sure that we continue to offer the standardized program to everybody, because that's what we know works. So let me pivot a little bit and talk about some of the more recent things we've been doing. COVID was generally very bad news for all of us, but there are a few silver linings. We are better at using remote communications, so we'll probably never quit Zoom or the future children of Zoom. Many people with epilepsy are now used to telehealth. Many more have digital access. Payers are more amenable to paying for remotely delivered services. So, and then one of the particular unique things about epilepsy is in most states, actually, I think probably all of the states, but the timelines are different. If you've had a seizure, you are prohibited from operating a motor vehicle, and that makes sense. Sometimes it's a year, sometimes it's 6 months. It differs depending on the setting. But we developed the SMART program, which is entirely virtually delivered prior to the COVID pandemic because of those travel restrictions that people with epilepsy often have to live with. But at the same time, I think the remote delivery has helped more broadly make this available to people with epilepsy who maybe don't even have seizures that frequently and may be able to drive or come to an in-person intervention. One example that we could model this on is diabetes. So parity with diabetes care can provide a useful model for epilepsy. Diabetes education is a standardized, widely available component in the medical management of diabetes. Usually it's used in conjunction with medications or other biological therapies, just like epilepsy. Diabetes self-management teaches people how to manage and stay healthy with diabetes. It's led by certified diabetes educators, CDCESs. Those educators help people with diabetes meet personal health goals, and it's standard care for many types of diabetes, type 1, 2, gestational. It's covered by most insurance plans, including Medicaid's. There's individual or group format classes, and in many cases, health systems will offer financial assistance for uninsured or underinsured individuals. So for me, that's kind of the vision, is let's take that diabetes education model and apply it to epilepsy and make epilepsy self-management, based on this body of evidence that it works and it helps people, to available to everyone with epilepsy. So these are the things we've done to try to further our getting closer and closer to that model. We have another CDC funded project, and that project involves partnering with 3 epilepsy-focused social service agencies: the Epilepsy Alliance of Ohio, the Epilepsy Association of Northeast Ohio, Epilepsy Association of Western and Central Pennsylvania. We have trained their staff. So these are community social support agencies. They receive a patchwork of funding so they can offer the SMART program to all of the clients that use their services. So we are running that. We're in year 4 now of that project. It's been successful. The agencies feel that this will be sustainable. Their staff now have the skills to deploy the program. We have another project called the Smart RM project. This is, we've received some funding from pharma. And what we've done with that is we've linked the SMART program, the epilepsy self-management curriculum, with a FDA-approved drug treatment. So for people that have a lot of seizures, there's FDA-approved nasally inhaled seizure rescue medication. So these medications are out there. There's a couple of therapeutics that are available. The problem is that people don't use those therapeutics appropriately. Just because you write a prescription doesn't mean people know how to use that and in the right context. So we've merged the two, and we're in the process of testing that right now. We've adapted it to different chronic health conditions. So Dr. McVoy, along with a health services researcher at the University of Colorado, has adapted and is preliminarily testing SMART in adults with brain tumor, so another neurological condition. And then we have another project called the Expand Project. I'll share more a bit about that, but it's a CDC funded project to embed SMART directly into clinical care settings. So a fair bit going on. This is some data that we just got from our SMART 3 project. So this is with the 3 social services agencies. So we're providing SMART, or we aren't providing it. The community agencies are providing SMART. We provided support and training for them. Our outcomes of interest were the 9-item patient health questionnaire, the 10-item quality of life in epilepsy, or QOLI-10, generalized anxiety scale, or GAD, and then self-reported seizures in the past 30 days. So we just got some data now recently on about 70 people, and we were able to show that, similar to time and similar to SMART, we could improve depressive symptom severity, we could improve quality of life. Anxiety didn't really change much. We didn't see that in our efficacy trials either. However, seizures looks sort of promising. We saw a numerical advantage. They went from about having 2 seizures a month to about 1 seizure a month. That did not reach statistical significance. We are continuing to collect data. I'm cautiously optimistic that if we can improve our sample size, we might be able to move that one as well. And then the most recent project is Expand. So that is partnering with 2 clinical entities, so the University of Cincinnati Health System, as well as the University of Iowa Health System. What we are doing with that is tapping into the electronic health record. We're using Epic to identify and refer people with epilepsy, prioritizing those who may have particular needs for self-management support and implementation in many clinical settings. We're still using that service delivery model of the peer educators and the nurse educators. However, we have trained people within the health systems to deliver the program. We do still have a stakeholder advisory panel to help us with implementing and making sure that we're reaching out to diverse communities, including people who live in rural settings. We think that Expand or SMART is particularly helpful for those who've had recent seizures, who have problems with medication adherence, those with mental health comorbidity. We are focusing on young adults transitioning from pediatric to adult clinical settings and those who live in rural regions. So this is how the EXPAND program works. So we've worked with the clinical teams to program EPIC so that patients complete a survey in MyChart, or they can complete it in a tablet in the waiting room. And if they seem like they fit some of those criteria that would make them particularly amenable to the SMART program, then that will trigger a best practice alert that appears in the chart when the provider next see the patient. So this would be the epilepsy care provider. As a third phase, the provider talks with their patient with epilepsy to see if SMART is appropriate and if they are interested in hearing more. If the patient concurs, then the provider clicks on the BPA to refer that patient to SMART. It goes to a infrastructure coordinator who schedules, puts them in a wait list for the next SMART group, and then SMART is delivered virtually by nurse and peer educators. So the groups are about 10 people in each group. Again, our team at UH in CASE has trained the nurse and peer educators at these programs, and these are delivered virtually, as we saw with the SMART program. We are helping to implement the BPA in the settings where people receive care. Interested nurses and patients may be able to be trained as SMART educators. It's not uncommon for us to have people come to us and say, I really like that program. It benefited me. Can I be a peer educator? And we generally try to be as inclusive as possible. We have a bunch of resources that are available, education on the self-management program, recruitment materials, screening tools, whatever we can do to help the systems enroll. We have had a number of talks with healthcare administrators to help them understand how they might benefit them and their program. So we do make pitches to the clinicians, to the staff, why should you do this? Why should you offer epilepsy self-management? We talk about access. We provide some of the data that we've had on the fact that rural people don't get care and they have more frequent seizures and they have more frequent psychiatric comorbidity. So it becomes an equity issue. It becomes an access issue. And you will facilitate changes that improve outcomes for underserved people with epilepsy. It's an opportunity for nurses to be trained as SMART educators. So we've seen that once our nurses get into the program, they tend to like it. It's a nice change of pace. The burden is not too much, so it's basically 8 to 10 hours for 8 hourly sessions spaced out over the course of about 8 weeks. We usually do ask the nurses to do a little debriefing with their peer educator, but for the most part, it will not take more than 10 hours to provide services to a group cohort. So. And then just very quickly, in addition to our work in rolling out and scaling up SMART, our team at CASE and UH has been part of driving something called the MU Network database. So what we've done is pooled data from clinical trials all the way from 2012, when the network first was really starting to accumulate these legacy trials. We've harmonized and pooled the data and done many different secondary analyses. And these are just an example of some of the publications that we've had. But the advantage to these pooled data sets is that you can do subgroup analyses or kind of longer term trend analyses that you can't do from a single trial. This is an example of one that we published several years ago now, where we pooled the different evidence-based self-management programs, and we looked at changes in the 9-item patient health questionnaire, depressive symptom severity over time. And so the black line is control, and the blue dotted line is people who were in one of the epilepsy self-management programs. We had almost 500 people in this analysis, and you can see that there was an improvement in the PHQ-9. So that was a clinically important and statistically significant improvement in depressive symptom severity for people that did evidence-based MU network programs. We have variables in our integrated database that span the full kind of socio-ecological domain, from biological, demographic, clinical, and community and social context. So we can do analyses looking at, for example, social determinants of health and who might do best or who might need some additional support with epilepsy self-management. We have some things in the road ahead. We recently got funded by NINDS to test an adapted version of SMART in the Ugandan global healthcare setting. So that's been exciting. We haven't started the project enrollment yet, but we're working on all of the infrastructure setup and data capture setup. I mentioned that Dr. McVoy is working to get some support for a project in adolescents and young adults. And I've been working with some teams in other countries to look at cultural and linguistic adaptations in global health setting, beyond sub-Saharan Africa. Our teamwork makes the dream work. It's a cliche, but it's really true. Everybody on the team really helps us move forward, from my co-PI at the University of Iowa, as well as our people here at UH and CASE, who enroll patients and engage them and help them stick with us in the study. And I just wanted to close with a quote from one of our patients who said, "I learned a couple of ways to help that I haven't even considered or known about. And since implementing them into my life, the number of bad seizures days I've had has gone down, which is really important to me." So reducing seizures is important. People do realize more global improvements in quality of life. And we hope that we will be able to continue to implement this evidence-based self-management program into both clinical and community settings to advance care for people with epilepsy. So let me stop there. Thank you.
Martha, thank you so much. As always, it's great to hear of the great work you've done over the years. Feel free either to put questions that you guys have in the Q&A, or if you can, unmute yourselves and ask questions, and I'll be keeping an eye on both. If while we're waiting for that, if you don't mind, I'm going to ask you a question. So as you get data that you can do this within and expand within the medical record, what do you do then to get it to be available for clinical practice? Like, do we got to harass insurance companies, or what do you do next?
So there are, so we have these two clinical sites that are doing this. We are working with our stakeholder advisory boards, includes champions and leads from other clinical settings, including epilepsy specialty care centers who are interested in doing this program. So I would say training their staff. So the big issue, the big, choke point, I think, is reimbursement, right? Fortunately, there are codes, both for healthcare worker codes and for self-management or chronic disease management codes, that I think would be appropriate. And that is where we're working with these center administrators to see about capturing data. So for right now, the staff are covered by the grant.
Right.
But for sites that come on next, that'll be, to be able to say, you're not going to make a ton of money with this, but if you can cover your costs, I think most, health systems would be okay with that, given what we know about the improvement in. So we know that negative health events are improved, right? So if you can reduce ER visits and you can reduce hospitalizations that maybe, could be better managed in the outpatient setting, then I think that's a win for everybody.
That's great. So there are theoretically codes that we could use already, reimburse this.
Yes,
Now it's like proof of concept.
and models where, people have been able to get benefit from them. So the diabetes educators, for instance, that's a good example as well, where you're able to capture billings from both Medicaid and private insurers. We are also happy to share. So the EPIC setup, the EPIC programming, we're happy to talk with other facilities about how to do that and how to pull the best practice alerts so that people, you can get the right people. That said, we've had so people might not have frequent seizures, but still feel like they can benefit from the program. So I would say, I wouldn't say that SMART is only for folks that have had a lot of seizures. They probably will benefit most in that negative health event outcome, but we can look at depression, we can look at quality of life, self-efficacy. All of those things we've seen from both our efficacy and effectiveness trials improve. So I would say if you have epilepsy, especially if you're a young person, relatively new in your epilepsy journey, I would say they're really an ideal candidate.
So we'll give everybody a few more minutes to let us know if they have questions. We really appreciate you being here. All right. What do you think? We calling it, Martha?
I think so. I appreciate everybody's time for their attention, and let me know if you have any questions or would like to talk about SMART or adapting it, or if you have your own chronic disease self-management program or working with people with chronic diseases. I'm happy to provide any input or thoughts. So thank you. Appreciate it.
Thank you, Dr. Sajatovic. Thank you, Molly.
Absolutely.